So today our topic is root caries. Last time हम पढ़ रहे थे class 5 lesions with the carious or non-carious lesions was involving the cervical areas. Or root caries is somehow the same, not same exactly. The difference is involving the root surface. So the class 5 lesions and root caries may it's a bit different that root caries involve the root surface. As you know, the separating point or the junction point between the root and the clinical crown is the cemento-enamel junction. So any lesion which occur apical to cemento-enamel junction in the root area is called the root caries. And mostly the same surfaces or facial surfaces, the lingual surfaces and the proximal surfaces could be involved. And so the difference in between these two is that the root caries involving the root area. When the root surface is exposed, so it is a root caries. So definition formally, the definition of the root caries is called the soft irregular carious lesion initiating or confined to root surface and cause the undermining of enamel at cemento-enamel junctions. So as I told you, the lesions initiate, sometimes they initiate at the root surface and it progress towards coronally and it causing the undermining of the surface, especially the enamel, but it is again it is called the root caries because it initiated at the root surface. So and sometimes it's only confined to the root area. So irregular soft, mostly they are soft lesions because the area of the surface to surface, like the root surface, you can compare it with the normal root surface. That area you find some softening or change in the discoloration. It could be yellowish more or in dark color. So it could be believed that the yellow color or lighter color, it is a more active than the darker color. But it's not so reliable, but it is a belief that the lesion which is more darker, that is more the inactive type lesion, and the lesion which has a lighter color has a more active, but it is mostly the softening of the lesion or the surface or the texture of the surface. The surface which is soft texture or the softer is more active than the surface which is harder and darker. So harder and darker is a more arrested or inactive type of the lesion, and soft and lighter color is a more active caries. So as I told you, it's only occur on exposed root surface. At the root surface, otherwise root surface is not exposed. Once it's exposed, due to the gingival recession, due to the other reasons, when the root surface exposed, then the caries may occur. As here you can see that uh, this maxillary canine, due to some gingival recession, and you can see here, so non-carious cervical lesion as well involving this canine, and in that you can see a spot here. The center is a soft and the difference in the color, and that is the root caries. So that root caries is typically, as per definition, involving the root area. As here you can see that root caries initiated at the root area and it progress coronally and causing the undermining or even the breakdown of the enamel. But it is again is called a root caries because it initiated at the root area and it then progressed the coronally. So there are the, as I told you, the susceptible areas which are more prone to the caries, and they are more vulnerable to the root caries. The root caries is more found in these areas, and especially, एक मिनट यार ये मिनट हेलो अस्सलाम वालेकुम हाँ हाँ मौसम खराब लगी भैया हाँ हाँ मां भी लेक्चर ही वठां पियो बस मां भी जो आहे त मां रिकॉर्ड कयां पियो लेक्चर जेके ॿुधी सघनि ॿुधनि जेके न त पोइ वरी मां यूट्यूब ते लॻाईंदुमि। हा पोइ हाँ पोइ ईअं पोइ मैनेज कयो न भला छा छा हा हा 11 खां पोइ ऑफ करे छॾियोनि भले हा। जी जी sorry. So susceptible areas where it occur more interproximal is more area commonly which the root caries occur because interproximal area, as you know, even in coronal caries, it is more because of the difficult to maintain the block control due to that areas, hidden areas of food infections could be there, and that area is more, and especially there's a periodontal problem involving the area, so the more root surface exposed, there could be a periodontal pockets and all that. In that, the root caries may be initiated, and the buccal surfaces and lingual or palatal surface, third number, and in mandible, it occurs from posterior to anterior. So molars are more, and then premolars, then crine, then anterior incisors. So this is how the more susceptible teeth in mandible, the order is posterior to anterior, while in maxilla, it is more anterior and then posterior. So the incisors are more prone to carry root caries, and then canine, then premolars, then molars. So the order is reversed in the maxilla. So this is how these susceptible areas. Here you can see a mandibular teeth, buccal surfaces are involved, and this is the root caries initiated at the root area, and it is a apical cement enamel junction, and you can see as a very active lesion here. It's close to gingiva, covered with the block, and it you can see it progress, either it progress coronally involving the enamel and undermining the enamel, or it may progress laterally. Here it's a lateral progression of the root caries into proximal areas. Here you can see in these proximal areas. So this is root caries is progressing. Here you the proximal interproximal area after exposing the surface, and this is the root caries involved here. This is the palatal surface of the maxillary premolars, the palatal area. This is the root caries involving the palatal surface of the uh, maxillary premolars. This is a darker, but it is a actively lesion. It's involving or close to the gingiva, and sometimes you can see here even a subgingival lesion. It's a progress. Typically, it may progress coronally, or it may progress laterally involving the interproximal area. So what is the difference between the root caries and coronal caries? With there, a bit difference, as you know, the surface is different. At the coronal area, there's the enamel first. The caries is starting enamel, and then it progresses toward the dentine. And here, the root surface area, you can, if you know the anatomy or biology of the root surface, that is covered with a cementum, and there is a junction between the cementum and enamel at the cervical area. And sometimes even there is a no deficiency, there's some gap between the cementum and enamel, and that gap is most so prone or vulnerable to this root surface caries. So the root here you can see a surface more vulnerable to acid dissolution than enamel, because enamel is harder, and the cementum, if you compare, it is less mineralized than enamel. So when acid produced by the you know but due to the metabolism of the carbohydrates by the bacteria, what's called the karyogenic bacteria, they produce acid, and that acid causes the dissolution or the demineralization of the enamel or the hard tissues like cementum. So cementum dissolves more rapidly than your enamel, because enamel is more harder. So that's how uh, root caries start at a 4.8 pH. as we know that enamel caries start at 4.6 or 4.5. So 4.5 is a critical level. When this level reaches, enzyme start to demineralize. But at a higher level, that your root caries start, because as I told you, the reason is that the root surface is less mineralized, the cementum covered, and then enamel is highly mineralized. So that is the difference, and that difference means in when there's a less activity in the block may lead to the root caries as compared to the enamel. So that is this is how that it progress more rapidly than enamel. It progress more rapidly than enamel, and reason is again same, that it is softer, it dissolve rapidly, the cementum, and then dentine even of the root radicular dentine is compared to coronal dentine. So radicular dentine is less mineralized, so that's why that is uh, more progressive. Bacteria difference is that morely the dominant, predominantly the in a coronal region or the enamel caries, the we know the Streptococcus mutans, the lactobacillus are predominantly play a role. However, in actinomyces viscosus in a root caries, again there are the Streptococcus mutants and the lactobacillus are also available, but it is believed that the actinomyces viscosus is a predominant agent of the bacteria, which has more role than the Streptococcus mutant and the lactobacilli in root surface caries. So this is somehow the here you can see a lesion here appear at this mandibular molar at this area, and that is the root surface area, and that is the root caries. And if you leave that without treatment, that it may progress for with some time. It progress, and you can see a progression here in all direction. It is progress in apical area, it progress in coronal area, it progress in you know the lateral area. The lesion is looks more darker. If you touch it, it could be a softer. So it is close to gums, and that is active lesion. So that's why I told you, don't only rely on the color of the lesion. The color, if it is looks darker, it means it is inactive. No, it doesn't mean that it is inactive. If it morely the inactive lesions or the arrested lesions looks hard, darker, harder, shiny, smooth, and that your texture is more smoother and harder. So and as I told you, it's maybe away from the gums and all these things, but so this is not looks as a smooth, shiny, or away from the gums, or it's so this is looks actively and it needs a treatment. As I told you, this is your previous picture. इसको देखें with smaller lesion and left untreated, and then it progress. So it is lesion is active. रिस्क फैक्टर है रूट केरीज के, ये टेबल है, मैं थोड़ा सा इस पे डिस्कस करूँ तो रूट केरीज के जो risk factors बहुत ज़्यादा हैं. As you know, the root caries mostly occur in older age because that more than 30 years, 40 years of age, because it needs exposure of the root. As in a definition, I told you that only it occurs in the exposed root surface. So the more in a younger to teeth or in a younger patient, roots are not exposed, especially it's covered with the gums and soft tissues. So once the soft tissue loss due to the gingival recession, due to the periodontal problems, these other reasons, then it occurs. So it occurs mostly in an older age group. So that is exposure of the root surface is in these age groups. Attachment loss, जैसे attachment loss है, again due to the periodontal problems and gingival recessions, attachment could be lost, and that leads to the exposure of the root surface, and then block retention, and then can leads to the root caries. Periodontal pocketing, the same, and especially in the interproximal areas. As I told you, the interproximal area, when there is a periodontal pocket occur, that it's a potential area of food infection, and that leads to the periodontal diseases and as well as the root caries in that particular area. Inadequate oral hygiene is same as coronal caries, and low priority to the patients neglecting its oral health, and physical impairment again in a more old age, or at old age it could be a poor physical impairment. This physical impairment is not able to brushing properly and maintaining the oral health, brushing, flossing, and everything, that could due to the physical impairment, and so more in older age. Cognitive impairment again, a mental disorders, that could be more in जैसे एज बढ़ती जाती है ये प्रॉब्लम्स भी होते हैं बहुत कॉमन. मेंटल जो डिसऑर्डर्स हैं वो भी ओल्डर एज में ज़्यादा हो सकते हैं. Aerogenic diet, of course, that is the same. Diminish the salivary flow and buffering capacity with the increasing age. Again, so these are more risk factors are more present in the root caries as compared to the coronal caries. So because in the root caries this occur in older ages. So in older ages, these problems most common also the occur, uh, and that leads to the more caries activity. Diminished salivary flow with the age, again, and buffering capacity reduced. Salivary flow again reduced by medical medications. Medications are medicines, as you know, that in again in older ages, some there are the medical conditions. Mostly they are taking the drugs. Medicines means in due to the medical problems. So chronic medical problems like diabetic mellitus, like hypertensive, and other problems, chronic problem, and they're taking drugs for longer time, antidepressant drugs, and all these. When any medicine we are taking for longer time may leads to the decreased salivary flow, what we call the xerostomia. And then there's surgical radiation therapy, and that could be due to the uh, cancer in oral maxillofacial area, physiological aging, as the previous caries, lesion restorations have a high risk already, lack of access to an interest in dental services, low socioeconomical status. So all these things, are risk factors in the uh, older ages increase for caries because of these problems. These are the medicine, and these medicine is usually taken, for example, anti-asthmatic drugs. Anti-asthmatic drugs, asthma is a long, lifelong sometime. So the drugs are continuously taken, and this continuous taking of the drugs or medicines leads to the disease. Anticholinergic drugs, anticonvulsant drugs, antidepressant, antiemetics, you for this is not मतलब chronic नहीं है एंटीएमेटिक्स, मगर for few कुछ टाइम के लिए that can cause the xerostomia, antihistamine, anti-allergic, anti-hypertensive. So these जो drugs, जो medicine जो मैंने आप बताया कि which are taken for longer time may leads to the xerostomia. And mostly in older ages, patients are taking the medicines. So diabetes, as I told you, for anti-hypertensive and all these things. These medicine decrease salivary flow rate, and all these things leads to the high caries. Here you can see this radiograph of mandibular molar and premolar, and you can see some initiating of lesion and cervical area, and here you can see some alveolar bone to they can crest of the alveolar bone, थोड़ी बहुत flattening of the crest at this area, and that leads to some periodontal problem as well. Here it progress more after कुछ time के बाद. You can see a more flattening and horizontal reduction of the alveolar bone, and that is uh, leads to the periodontal pocket formation, and that again a more progression, and here you can see a more loss of the bone, and due to the loss of the bone, the area become potential to food infection, all these things, and that leads to the root caries as well. And this is a well-established root carious lesion in these molar and premolar both simultaneously because of periodontal problem on pocketing that cause the uh, food infection, and that leads to the root caries. Treatment strategy of the root caries are preventive and chemotherapeutic, of course, and restorative, as same as your coronal caries. Now, preventive and chemotherapeutic strategy, uh, here the root caries can be controlled or arrested by block control, diet modification, fluoride application, and antimicrobial agents. Block control, how can you, as we discussed, that block can be controlled by uh, brushing and by flossing, mechanical mostly you can see, say that is you can control the block, diet modification, the diet counseling, and you know that the diet patients, mostly patients again we old age may taking more softer diet, and that softer diet may leads to the more carious activity. Fluoride application and antimicrobial agents may play a role. Fluoride, there are various ways to use the fluoride applications. The gels are available, what we call the acidulated phosphate fluoride gels, which make used at the chair side. High fluoride containing toothpaste can be prescribed, which contain at least 5,000 ppm, and regular your toothpaste contain 1,000 to 1,500 ppm. So high fluoride content toothpaste could be a very beneficial for these patients which have a high, because as I know the caries, root caries is most rampant type of the caries. एक तो मेडिकल कंडीशन पेशेंट्स के ओल्ड एज होती है तो और भी प्रॉब्लम सलाइवरी फ्लोरेट जैसे मैंने डिस्कस किया, रिस्क फैक्टर्स बहुत ज़्यादा होते हैं, तो इसमें रैपिड केरीज होती है और प्रोग्रेशन ज़्यादा होती है, mostly involving the multiple teeth same times. So these type of the toothpaste is well, could be effective in these cases to control the caries. Fluoride mouth rinses भी आप prescribe करेंगे. Fluoride varnishes even available. Fluoride varnishes देंगे, and the fluoride varnishes contain the more high level of the fluorides up to the 25,000 ppm. So the intraoral fluoride releasing devices available, and the devices are attached to the tooth surface, and they're slowly releasing the fluorides and continuously reinforcing the tooth surface against the caries. Fluoride chewing gums thing. There are different ways to apply the fluorides, and fluorides आप यहाँ पे देंगे. देखें दो कैटेगरीज हमारी होती हैं, एक बच्चे और बूढ़े, तो केरीज दोनों में ज़्यादा होती है, बच्चों में भी और बूढ़ों में भी, तो इसलिए फ्लोराइड एप्लीकेशंस इज इम्पोर्टेंट इन दीज बोथ कैटेगरीज. Antimicrobial आप देंगे यहाँ, which could kill the bacteria. This is because of it's a bacterial infection. Our carcinogenic bacteria are there. If you kill the bacteria, you may control the dental caries, and the chlorhexidine mouth rinses effective in both for the caries and for periodontal problems as well. And 2% chlorhexidine mouth rinses, and chlorhexidine varnishes are also effective or available, and they can be applied. And third thing is xylitol. Xylitol is again a carbohydrate but cannot be metabolized by these Streptococcus mutans or carcinogenic bacteria. Xylitol, chewing gums mostly are available. The xylitol as a highly effective, and it's written that there are up to 80 to 85% the successful rate to control the caries. So xylitol to chewing gums are effective. These kind of what we call the chemotherapeutic strategy to control the, because यहाँ आप देंगे again reason वही है कि multiple teeth are simultaneously involved. The caries activity is so rapid and so that you have to control it. Only a restorative treatment could not be sufficient. Because restorative it is मैं शुरू में भी कहता हूँ कि it is not actually the treatment or of the dental caries. It's not controlling the dental caries. It's only repair a damage, but it is necessary to make a strategy to control the dental caries. If you cavitation is there, you need to restore it, but for with the restoration you have to also chemotherapeutic or preventive measures you have to take. Restorative पे अगर हम आए तो last time we discussed the restorative options for the class 5 lesions. So somehow the same way you have to treat the in terms of the restoration of these root caries as well. As here you can see it you for retraction and exposing the surface. Uh, Last time हम discuss किया था, this is a clamp which we call the butterfly clamp, or the number is SA22212. So that is a clamp is used to retract the soft tissues and that expose the this area even if it's a root, and that expose cavity. Here you can see, and you can remove the lesion and then you can restore the lesion. Silver amalgam can be used for the restoration of the cavity at the root surface, and you can see here very long lasting restorations and very smooth and less you know retention of the block can be easily maintained. But problem of amalgam, as you know, that you need a cavity preparation, proper box type cavity preparations, and uh, color is for in the area which is not visible, like a cervical or root area of the mandibular incisor teeth. These are the just जो आप देख रहे हैं, the mandibular incisor teeth. This area is not visible during talking, smiling, and anything. So that is the area you can use the amalgam. So here you can see a composite, resin composite. Material of choice could be resin composite because of its color. You can see a very in the area which is aesthetic zone, or in any area in a premolars, in a molar area, in any area you can use a resin composite. And with the polishing and all these things you can give a luster to the surface, and that if it's a more polished surface have a less retention of your block, and that is the it will work. But problem here have of bonding to root surface, it is actually somehow the compromise as compared to the coronal जो enamel के साथ bonding है या dentin के साथ, वो bonding is difficult sometimes achieved in the root surface area, because the bonding to cementum and roots dentin is you know difficult, or it is not so good as compared to enamel. So that's why here you can see this maxillary canine. It is filled with that composite restoration, and with the after time you can see a dark line appear, especially at the cervical area or apical area to the restoration, because of again poor accessibility leads to the poor bonding to the this gingival area, to our gingival floor आप कह सकते हैं, so that are overhang sometime. So this is the darker line appear here. It indicates that it is micro leakage, or it is bonding failed, and that leads to the staining, and that leads to the secondary caries, and finally it needs to remove the restoration and replace the restoration. So this is a common problem in a resin composite restoration, because of poor bonding with the root surface, less accessibility, poor sometimes isolation because of the gingival bleeding, and sometimes gingival fluid. So these things leads to the poor bonding to the root surface, and that poor bonding leads to the micro leakage and secondary caries, block retention, all these things. But it doesn't mean it is it works better if you control these factors. So glass ionomer, so it is the could be a material of choice. As you know, there are some advantages in a glass ionomer. As I told you that it's caries in the root caries, especially rampant type of the caries involving multiple carious teeth same times. So glass ionomer, you know, the glass ionomer, when you use it has good bonding even to the root surface and is releasing the fluoride, so it has a effect on controlling the caries as well. And but the problem with the glass ionomers, it is opacity. So the glass ionomer can be used of different version of the glass ionomers. It's a conventional glass ionomer, the resin modified glass ionomers, so compomers you use that, and that can be covered with a composite words. Last time we discussed the sandwich technique. So this is the simply uh, root caries and its risk factors, and it is the treatment, restorative and preventive treatment, and mostly we rely on the preventive treatment as well, because sometimes restorative treatments are not possible, and the different multiple teeth are involved. So preventive strategy is more important here. So thank you so much. This हो गया आपका आज का lecture, and the next time in I think your course of this operative key topics almost completed. So next time we will start the endodontic treatment. But before that, I want to take taste. I don't know. I have need to talk with Kader Saab, and this could be that we there must be